Hello viewers, welcome back to my YouTube channel Dr. Mohsen. Today we are discussing the laparoscopic cholecystectomy procedure, which is a minimal invasive technique for the removal of gallbladder from your body. Before discussing it, we should know the indications of cholecystectomy that include gallstones, cholecystitis, biliary dyskinesia, gallbladder cancer, gallbladder polyps, or gallbladder pancreatitis. Laparoscopic cholecystectomy procedure step is discussed in this video. So let's start. First of all, we have to do the scrubbing of the hand, then gloving of the primary surgeon who is performing the operative procedure. Then patient is positioned into the reverse Trendelenburg position, in which the patient's head is tilted up and legs downward. Operating table is tilted toward the right side for the better visualization of the gallbladder during the procedure. And the then patient is put under the general anesthesia. We will start from the scrubbing of the patient with the pyodine or chlorhexidine solution. Then a port is created at the umbilicus. The port should be around 10 mm for the camera. Then we have to pass the trocar through the umbilical port. When the trocar is passed into the umbilical port, the trocar has been secured so that there should be no escape of the pneumoperitoneum created by the carbon dioxide. If there is a leakage, the carbon dioxide will leak from that port side, and that will cause the loss of pneumoperitoneum. Another port is created just below the xiphosternum for the working of the instruments. This is known as the working port. In addition to this, the third port is also created, but before that we have to pass the camera through the camera port or subumbilical port so that we can have a better visualization of the peritoneum when we are passing the trocar for port. So now we are making a third port site for the grasping of the gallbladder, because there are various methods for operating the cholecystectomy. Some surgeons prefer the 4 ports for the operating procedure, and some prefers the 3 ports. That depends upon the capacity of the surgeon. When the port has been created, the pneumoperitoneum has been obtained. Now we will go for retraction of the gallbladder. The gallbladder is retracted through the grasping instruments, and then the adhesions of the gallbladders are removed via the working port. The adhesions are removed. In that case, we have to identify the callous triangle of the septic triangle. When the callous triangle is identified, we have to check whether that is a cystic duct or the hepatic artery. Of course, damaging the cystic duct or hepatic artery could cause adverse effects to the patient's outcome. So, now the surgeon is going to remove the adhesions and identify the callous triangle. When we have the cystic artery or cystic duct in visualization, we have to identify it and then perform the clipping to that cystic duct. When the clipping is applied over the cystic duct and the hepatic artery is also clipped, then we will go for the resection of the hepatic artery and cystic duct through the scissors. After clipping up the cystic duct and hepatic artery, then now the next step is to separate the gallbladder from the liver bed. Slowly via the diathermy, the gallbladder is separated from the liver bed. When the gallbladder has been separated, it is collected in the endo bag, and then the gallbladder is removed through the umbilical port, which was 10 mm in size. After that, for the safety purpose, we are going to use the drain which is placed subhepatic. When the drain is placed subhepatically, then we have to secure the drain with a silk suture. After that, the port side